Assalamu alaikum and good afternoon to all of you. It gives me actually a great pleasure and honor to introduce our next speaker for this session, Professor Matthias Gukenberger, who is an ESTRO president and the chairman of Department of Radiation Oncology and for professor at the University Hospital Zurich and University of Zurich. He is a member of the RTC Radiation Oncology Science Council, and his clinical and research focus actually in image-guided high-precision radiotherapy, especially for the lung, prostate, and oligometastasis, the field which is very important nowadays in our daily practice. His work is published in more than 350 PubMed-listed articles and with the 2 patents. The scientific achievements have been acknowledged with several national and international awards. Mostly, the most recent one, actually, the honorary physicist by the ESTRO Society in 2019. He'll be talking about the emerging opportunities in radiation oncology, overcoming dissemination and implementation challenges. Please join me welcoming Professor Matthias.
Good afternoon. It's a pleasure and honor speaking here, and I would like to congratulate AMSTRO for 2 reasons. First of all, for the establishment of the society, for your mission and your vision, but most importantly, again, to giving the voice of patients such a prominent place on the stage. And despite I'm being a clinician here, I would also kind of like to give you a perspective of a different kind of patient which has been contributing to the work which I'm currently doing as the president of the ESTRO Society. So this is one of the slides where we are always quite proud of as a radiation oncologist. We're at this interface between technology and patients, and that is a curve we always like to see. It's going ahead, it's increasing the precision, the value, and thereby also the sophistication, going from technologies like 2D radiation, stereotactic to flash and whatever. That is a technology perspective. Sometimes we also need to be outspoken, say this technology is not what we are there for. We are there for providing value to our cancer patients. And sometimes I will touch that later on. We are not the best communicators of what we can achieve today already for our cancer patients. I have picked here 3 examples where we are coming very close to this goal of providing uncomplicated cure for cancer patients. May it be prostate cancer, early stage lung cancer, early stage rectal cancer patients, where more than 90% of the patients are being cured in an outpatient setting using modern forms of radiotherapy. That is something we can be proud of as a discipline, where we can be proud of that we integrated radiation oncology into multidisciplinary cancer care. The question is, are we fulfilling what is being expected by our patients? And it's always difficult to assume what is the future of cancer care, what are the expectations on the future. We heard the voices of patients already, very importantly. I have found another piece of an illustration of the future where maybe we can learn also something. Let's hope that this movie here works. This is from a science fiction movie. You may not have seen it. What you can see here is a mother with a daughter having cancer. You can see they are being not in a hospital environment. This is just distributed care. You have an integration of diagnostics and therapeutics. There's no medical doctors here which are being needed. Obviously, they need to be taken care of, but that might not always be available. And then, well, the patient is being treated in this outpatient, in a distributed setting, without having to travel to Boston, to Zurich, or to Geneva, these places which can provide fantastic care, but not to every cancer patient worldwide. So we need to make sure to deliver this excellence, not just in few centers, but to make it available for our patients on a global scale. And there's many developments in oncology, in science, where maybe we as radiation oncologists are not embracing enough the innovation which is happening around us. And there's so many opportunities. AIs have been mentioned before, but there's many others more. So it is really a call for collaboration and embracing all the innovation which is happening, and to indicate what makes value for our cancer patients, where we can learn from science and innovation happening next to, call it, traditional radiation oncology. That's what I try to emphasize with the theme of the last year's ESTRO meeting, transformative innovation through partnership. And at the opening ceremony, there was a patient speaking. That was Pascal Uffer, and he was diagnosed with stage 4 lung cancer patient. And the diagnosis was made at the same week when he was awarded as the startup company of the year in Switzerland. So he has different hearts and philosophies. So he knows business. He's an entrepreneur and he's effectively disrupting some industries. And at the same time, he was a patient. I spent quite a lot of time with him, exchanging what are the expectations of someone who's disruptive, who understands business, and at the same time has a good understanding what he experienced as a patient, the positive aspects, but also maybe the negative ones. We've been preparing his talk quite long, making me better to understand what is happening in the business side at the forefront of innovation, and for him better understanding what is the background of my experience I'm having as a cancer patient. We tried to summarize these findings from our both perspectives in this editorial, so please have a look and read it to understand how we put his perspectives in the context of cancer care and radiation oncology. What Pascal kind of proposed is the 5 C's of innovation. We should take better care of collaboration and partnership. That's what I am here for, that's what we are here for, to take care of partnership and collaboration, learn from each other, and support each other in this drive for delivering better cancer care for our patients. Communication. We need to be better communicators about the challenges, but also of the opportunities we provide already today. Learning from every customer. I will show you that clinical trial research is very important, but it has become way too expensive. We need better learning experiences from every single individual cancer patients to make it more cost efficient and also more rapid. We cannot afford waiting for 20 years and the technology is outdated when the clinical trial is being reading out. Cost effectiveness. We as clinicians, as a scientist, I don't like to talk about cost efficiency, but we need to. It is a goal per se to improve and make our innovation accessible to a large number of cancer patients. And finally, it's about the culture. We know that we are not having sufficient numbers of radiation oncologists, not sufficient numbers of nurses, of RTTs. We can complain about it, but maybe we also need to work better on the culture we are having in our society, in our hospitals, that people see what they can contribute to the society and are being engaged and motivated to join us and to enjoy actually the work we are having as clinicians, RTTs, and the nurses. So let's have a deeper dive in these 5 C's of collaboration. This is one quote which has been proposed and which has been, where Pascal Uffer has been exposed. Don't worry, we will protect you from the radiation oncologist. We were just hearing about customer service satisfaction. If you go to a 5-star hotel, you expect the reception with the spa and the hospital and in the restaurant to be perfectly aligned. There's no competition about the customer. And the same should happen inside of a hospital. There cannot be any competition between disciplines. That cannot be between societies and hospitals. It needs to be a unified customer experience to the benefit of our patients, to the benefit of the customer. That is what is being expected if you pay money or not. That is the service we are providing. We are service providers. And that gives an example where we've effectively failed in my own hospital to provide that service. Is that being affecting the access to care? Yes, it does. This is data from Europe about the access to radiation, the utilization. We know that radiation is not being utilized as it should be. And this is not only about resources. I marked here the countries of Denmark and Switzerland. Believe me, there's no lack of money in Switzerland for healthcare. We have too much equipment. And still, only 70% of the patients are treated with radiation therapy, despite all the resources are being available. So there's a failure, even if money is being spent. And I'm a strong believer it is about this. It is about people living in silos. And these silos have different names. They can be between public, private, academic. They can be between disciplines and professions. It can be between providers and industries, regions and countries. That is what keeps innovation and access from our cancer patients. And that is something where money is not going to solve the problem, where we need partnership, collaboration, and a dialogue to break these barriers and to bring care, radiation oncology, and all other to our cancer population. And there's data that in particular radiation oncology is being affected. This has been a review or a study about the effects of reimbursement on the provision of cancer care. Then there was a fundamental difference. It is not a surprise that reimbursement does drive care. That's what it's there for. It should be good incentives to provide excellence, to provide quality. For medical oncology, the reimbursement didn't have an effect whether patients were treated with the correct drug. It was about the drug which was being chosen, drug A or B, they were being in the same class. However, for radiation oncology, it was self-referral, which was driving the treatment using radiation. So if your center does have radiation, patients are having access, but if your center doesn't have access to radiation, it was not being provided. These are the silos we are living in. We need to break down. Incentives need to be developed to achieve better access in the first, second, and third world, if you would use these names. The second is about communication. And I have to admit, radiation oncologists are many times not the best communicators. We like to talk about toxicity, side effects, technology which no one understands. And this is a problem because people do have access to information, social media, and so on and so forth. We heard it before that the quantity of information is not an issue, but it's the quality effectively. There's quite good data that it's effectively the worst quality of data which is having the most frequently access. So this is a study about the 50 most popular social media articles about the 4 most common cancer sites. 30% were having misinformation and 30% were containing harmful information. That is not really surprising. There's bullshit being out there, call it fake news or whatever. However, the scary part is this misinformation and harmful information is what's being accessed the most. So that's driving the access. It's not the high quality. It's not the trustworthy information because we are speaking the wrong language to reach patients, to reach parents, and that is important to bring the message across. And that also affects the perception of our discipline of radiation oncology. I've shown you this beautiful graph of the development of technology. So effectively, every newspaper should celebrate the advancement in chemotherapy, immunotherapy, targeted therapy, and in radiation oncology. This has been an article in the Green Journal, and it did report an increase in communication about radiation oncology. But the perception actually decreased. So here is the positive perception decreasing and the negative perception increase. And it was mostly about concerns of side effects and toxicity. So all the technology development, it goes into a direction of being more outpatient, better tolerated, but our population learns about the opposite. So we need to be more proactive and get this message across what benefit we can provide to our patients. Learning from every customer. Every patient should count. And my patient asked me, how can you make sure, Matthias, that my experience, that my success or failure will influence the next cancer patient treatment? You can call that a rapid learning system, but currently we are stuck in a framework where we are designing prospective randomized clinical trials. They are very important, but they are a shortcoming. First of all, this is the facts that only 10% of the evidence we're having in radiation, the patients we are treating, is based on randomized evidence, clearly indicating that we cannot keep up with the pace. We cannot generate randomized evidence for every cancer patient. The money is just not being there. And it is getting worse and worse. This is about the funding. Look at how much of the funding is being dedicated to radiation oncology, where we know that 50% of the cancer patients are receiving it as a treatment. Only 2.8% of all research funding goes to radiation oncologists. Even worse for surgery, only 1.4%. The rest is going to other fields. So there's an absolute lack of funding being available. And this in a scenario where the costs and the efforts for clinical research are increasing ever and ever. And I just picked two random examples. You might call them a bit simplistic, but the length of consent form increased by 50% within 5 years. Many of you in the room are doing clinical research. Which of your budgets has increased by 50% in the last 5 years? Mine's haven't. And that needs to be paid, and patients don't understand it, why they have to read 20 pages before they can be enrolled in a clinical trial. That has implications, of course. It takes months and years from a bright idea to get it implemented into a clinical trial environment. Progress continues. And this is a cost perspective. To treat one single cancer patient in a prospective randomized trial is about $100,000. This is not sustainable. We cannot keep up with this pace in developments. We cannot generate sufficient high quality evidence having these delays and these costs. So that is where we need to make better use of all the digital information we have. I'm always saying radiation oncology is the discipline which is fully digitalized. Everything is being recorded, imaging, treatment. No discipline can come close. So we need to embrace all these developments in rapid learning, artificial learning, whatever you would call it, to make benefit of these treasures we have on our area, on our mosaic systems, to learn from it, not in 10 years, but in a much more rapid time frame. Next, about cost effectiveness. And this is a quote which makes people scary about artificial intelligence. Within 10 years, AI will replace many doctors and teachers and won't be necessary anymore. I think it was just last week where I heard Elon Musk talking about his robots, Optimus Prime, not Optimus, but Optimus Prime, whatever you would call it. And he said, well, within 3 or 4 years, they will be able to do any surgery better than any other surgeons. And I would say this is absolutely needed because already today, we are not having sufficient capacity. This is a back of the envelope calculation. We are underutilized radiation oncology by 20%, understaffed by 10% already. Cancer growth within 50% in the next couple of years. So without any automation, we will not be able to serve our patients. So we as a discipline need to embrace this opportunity and integrate it into, let's call it human AI interface to cope with all the cancer patients which we are seeing. We could not treat them otherwise if we would not make use of these developments. And finally, we do know that we do not have sufficient numbers of clinicians, of RTTs and nurses who are willing to accept this fascinating job. I guess everyone is sitting here not because the weather outside is beautiful, because we're going to have a beautiful dinner, because we're passionate. We love what we are doing, and it is so rewarding being in cancer care and being a radiation oncologist. That is the message we need to get across. Then I have no concerns that we will have sufficient next generations, but we need to work actively on it. This is a quote from business: take care of your employees, and they will take care of your business. So that is our obligation as leaders, be it of a society, be it international leaders, be it within our hospitals, and then allowing it to grow. And we're seeing that in some countries it is difficult. In Italy, there have not been any residents in radiation oncologists in the last 3 years. That is something where we need to break boundaries and motivate the next generation. So again, please keep this perspective of a patient merged with a society perspective of the ESTRO society in the back of your mind. Within the ESTRO society, we also considered how can we move our discipline forward? How can we develop, contribute from ESTRO side to these developments. And we proposed a paradigm shift from pure delivery on pressing a button to strategic taking care and responsibility for cancer patients. So traditionally, we have been focused on technology beam delivery. And that should shift to a strategic cancer care. We have way more competences than just knowing how the beam will enter the patient and will exit the patient. And that is something we need to develop and integrate into a multidisciplinary cancer care setting. It is breaking the silos I've shown you before into an innovation-driven discipline, which is cross-connecting globally, regionally, but also across disciplines. It is about the scope. We need to leave these discussions about technology. I started my research about high-precision radiation. That's an important component, but just one out of many. And we need to have a broader scope, how to integrate, collaborate, personalized strategies, and also kind of support our patients, decision makers, politics in the decision-making processes. So we would like to position radiation oncology not just in the basement, but in the center of cancer care, having expertise, knowledge in how to take patients' care from a systemic perspective, advancing technology with all which is out there and being developed. Biology, we do have radiobiology within our societies, and we need to have a better understanding how we can integrate radiation, maybe also in a different way, low-dose radiation to combine with immunotherapy, strategic sequencing, and finally also continuous patient care. So we propose 5 pillars how to further develop radiation oncology and how ESTRO could contribute. The first is again about inter and multidisciplinary focus. That is key in the oncological arena, and we need to speak on an equal eye level. The second is obviously combined modality. I had some questions about radiopharmaceuticals. If there's competition, yes, it is. But this is not bad. Competition drives everyone forward, makes us become better, makes us together become better. So I'm always in favor of competition to make the best for our cancer patients. It's about education, research, and leadership, about oncopolicy and advocacy, and of course, as centrality and partnership. So I will skip this and come to this slide again. Please read about the statement of a patient and our manifesto from the ESTRO Board of Directors to advance cancer care, to advance radiation. And I would, of course, also invite you in partnership to collaborate with the ESTRO Society. The theme of the next year's meeting is innovating radiation oncology, and the most important component is together. We will invite leaders from different disciplines. We will invite leaders from the perspective of patients. We will never have a meeting where there was so much patient involvement. We need this collaboration, dialogue, and partnership. So thank you again, ASTRO, for starting this dialogue, for engaging this partnership. ESTRO is very honored being invited here and contribute to this partnership. And I'm looking forward to many fruitful discussions, how we can better advance radiation oncology, cancer care, the health of our patients, and quality of life together. Thank you very much, and looking forward to your dialogues.
Thank you so much, Professor Matthias, for this really an excellent talk and touching the innovation radiation oncology, who practice radiation oncology, and other colleagues in the field. We have seen the innovation over years for the last 25 years, moving from 2D to 3D to the VMAT to the IMRT, for the proton therapy and other using the MR and using the PET scan, taking the advantage in the technology improvement in radiotherapy planning. But still, this is really the beginning. Of course, the future, a lot of work has to be done to try to improve even the practice of radiation oncology as within the multidisciplinary discussion and domain. And I like really the slides that you mentioned, that you take care of your staff so they can do a better business. And of course, they can serve our patients in a better way. And also the other statement that you said, probably radiation oncology is a bit tough while dealing with the patients. So we have always, as a radiation oncologist, to improve our skills in communicating with our patients, not just in the clinic, to say that we will be treating by VMAT or IMRT, the latest technology, or MR or proton, and these are the list of the side effects that you'll expect. Probably the human touch is, as we heard from the previous speakers, is very important. How to communicate and how to the patients and how really to increase the skills and refine the skills of the staff, of your staff, how to do it, especially the new generation of radiation oncology. Thank you so much for this.
Thank you, Professor Matthias, for always being so inspiring and motivating. In the interest of time, I would like to call upon the chair and co-chair of next session, Dr. Sundar Yahya and Dr. Murad Salam. Thank you.